Okay. Okay. Right. All right. Shall we kick off, and shall I just say a couple of words by way of introduction? Yeah. Super. All right. Well, thank you everybody for coming along. This is a final presentation from a. Oh, I think we've just got somebody. I'm just going to put everybody on mute. Just for noise. Okay, so thank you everybody for coming along. This is a final presentation from the Clinic Letter Creation Project. This is a deep dive operational study which the Institute for Manufacturing have been doing with CUH, with Addenbrooke's. It's great to see so many people here. We wanted to do this because above all, as a hospital, it's important that we communicate effectively with our patients and with primary care. I work in strategy within the hospital with Dan Norton-Jones, and have a strong link across to Rachel Fenner, who works in the primary care liaison office. And as a hospital, we're very dedicated to continuous improvement, and we've heard throughout the year, and actually over a couple of years, feedback from primary care that there can often be a high degree of variation across communications we send out. So we're delighted to work with the IFM to run a project to understand the degree of this and the causes of this, look for ways in which we can improve and support each other as a system. This is even more important over the next couple of years as we move to an integrated care system and think about, how we work together for the entire chain of care for the patient with their best interests at heart. So I'm not going to speak for any longer. I'm very excited to hear what our colleagues from the IFM have found, what we should do as a hospital, and why. So if I could just hand over to the project team and just ask you to introduce yourselves. Thank you.
Thank you very much, Daniel. Can you all hear me? Perfect. So our presentation is titled Clinic Letter Creation in CUH and Processing in Secondary Care, and it will be presented by myself, George, and Ian, who are my colleagues on this project. So I'll just start off going through the agenda for our presentation. So first of all, we'll be going through an introduction to the project, and then we'll be moving on to mapping the processes, and then the project findings and recommendations. And then lastly, we have a quick summary and have an overview of the benefits and recommendations of the recommendations. And finally, we'll just have a close and a quick audience Q&A. So before I start, I just want to say thank you for taking the time for meeting with us throughout our project and, all the valuable input we had. And I can see a lot of people are in the audience today who have joined us and have met with us. So lots of patients and CUH staff and primary care staff. So thank you all for all the time and efforts. So without further ado, I'll just go straight through to the introduction. So just to introduce the project. So we are working on a student project as part of our M4 course in the Department of Engineering at Cambridge University. We investigate the clinic letter creation process in CUH. We started off by making process maps and just looking for opportunities for optimization. And so we spent the last 2 weeks really in between Addenbrooke's Hospital and Stapler Medical Center, which was the primary care center that we focused on. So as part of our project, we met with consultants across the whole Addenbrooke's departments. We met with patients, medical secretaries, GPs, administrators, and the operation team. And so as our project was only 2 weeks, we just limited our scope and we investigated mainly on the diabetes and the dermatology departments. And so we had a look at lots of letters within those two departments really. And so just before we go through our presentation in much more detail, it's really important that I mention that all our findings, they really are preliminary, and these are just observations, and our results are only presented as proposals only. So just quickly, I'm just going to summarize quickly, the problem outline of what our presentation tried to tackle. So we identified a backlog of up to 2 to 6 weeks in sending out letters to GPs and patients from CUH. Just to get an understanding of the scope, it was around approximately 3 million letters that are being sent out a year. These are across 3,000 different clinic letter templates. That's one of the challenges that we are going to be trying to tackle within this presentation. And secondly, is that we identified an identical backlog in the primary care provider network. And the particular one that we were observing, which was Stapler Medical Center, we identified around 400 letters that were waiting for the GPs to process. And another one of the challenges that we are trying to tackle also is, the patients, the impact to patients within the clinical letter process, and just trying to improve the understanding and clarity concerns that can arise within these letters. So what can potentially be done to resolve these challenges? So the answer that we have proposed, is to streamline the communication. This can be done by, potentially reducing the delivery time of letters by 25% in the primary care process, and also by improving the patient experience, and also, incorporating and also support to mention that, it will also reduce the burden on GPs and CUH, and most importantly, also is to free up, the critical NHS resources. This is exactly what will be discussed in the presentation, and hopefully we'll try and find out how exactly you can obtain these important benefits. So I'll just hand it over to Guillaume now, who's going to start mapping the process in our project. Over to you, Guillaume.
Thank you very much, Hassan. So as Hassan presented, we try to find solutions. And before really understanding how we reach these solutions, we need to understand the whole process of these clinical letters. And even before, really describe well what is a clinical letter and what's the scope of our study. So, definition of the scope. There are many information that are transferred from primary care to patients to secondary care, so Addenbrooke in our case. But we really reduce our scope to the clinical letter, which is the letter sent to the patient and to GPs, to primary care, by secondary care, so the hospital, after an appointment in the hospital. So the GPs has prescribed an appointment to the patient to go to the hospital, and then he will receive a clinical letter, and the patient also, to understand what happened. And so by this scope, we have three main actors, which are actors in all the process in the healthcare, which are patients, primary care. And so we focus on Stapler Medical Center, and we want to thank them again for the time they gave us. Same, of course, for all the patients we interviewed. And in secondary care, we focus on Addenbrooke Hospital. So thanks again. It's very important to understand, and I think everybody is already aware, but it was important for us also to understand that these clinical letters benefit to all these actors, from, of course, patient, which is the main purpose of the letter, to give them information, but also primary care to follow the patient and understand what's happening, but also to secondary care, as it's really important for them to catch up. And these letters are also a way for them to remember what happened to the last appointment. So now focusing on the content of a clinical letter. So as I say, this is secondary care to primary care and patient. There is two main streamline. The first one, sorry, some difficulties with the PowerPoint. The first one is administrative information, which are mainly contained in the header, in the best, when we have really a proper letter, with contact information, dates, clinical, the date of the clinical meeting, the actual date, the addresses of everybody concerned, but also, of course, medical information, which are the most important, with diagnosis, management plan, follow-up, medication, but also many others information. And so we're going to try to break down these two processes to understand how we can improve both of them. So now, let's focus on secondary care. So patient had an appointment with anyone in the hospital, so consultant, registrar, clinical specialist nurse, clinical nurse specialist, juniors. And what would happen just after? There is two options for this healthcare professional. The first one is that they're going to write the core of the letter themselves. It will take approximately 5 to 10 minutes. All the numbers you will see here are very rough numbers. The goal is not to get precise number, but just an idea of the time it's taking. So when they write the core letters, there are different processes that we will see after, but maybe they will take their clinical notes and then copy paste into the letter, or directly write the core letter. So 5 to 10 minutes. And the other way is to dictate the letter to them, to the medical secretaries. This dictation is very variable. The time of the dictation is very variable depending of the consultant, registrar junior, or clinical nurse specialist, and it takes approximately between 3 to 20 minutes. I will summarize consultant, registrar, junior, clinical nurse, but just consultant, but we are still speaking about everybody. So when consultants or the others wrote the core of the letter, then they will send through EPIC this paper to the medical secretary's office, and then they will do something called proofreading. Oh, so operating too early. Proofreading, so which is basically two main things: putting administrative information, because the consultant already put the medical information, but also do something really important, which is sanity check, saying, for example, if the consultant is the letter said that they need to have an appointment in the next few weeks, the medical secretaries will be very careful that this appointment have been put in the system and so have been scheduled. And so the other way to transmit information, when the consultant has done a dictation to transfer the information, so the medical secretaries will receive an audio file with various form, so it can be tape, but also audio file thanks to Olympus, or directly electronic dictation thanks to EPIC. And then they're going to have to write the core of the letter. It can take 5 to 30 minutes, of course, depending of the letter, the content of the letter, its complexity, and its length. The main purpose of all of this is to say that we try to break down the process in simple cases, but in fact, in dermatology and diabetes, there is a huge range of different letters and a huge variety of letters, and we're going to try to standardize what can be standardized, but we still really understand that this process is very complex. And the purpose of the numbers you see is not to say that writing call letter and proofreading is faster than dictating and then let the medical secretaries to write the call letter, because everybody is used to their own way. Like some consultant prefer to write, other dictate, and so they need to keep what is the most efficient for them. And then medical secretaries could sometimes have to send back the letter to the consultant to do a double check, which is not mandatory, really, depending of each consultant, but can also increase the time of the process. And finally, the letter is sent to the patient and GP. Next slide. So when we went to the dermatology and diabetes department, first of all, we were very impressed by the fact that these two departments, it's quite obvious, but are very different, of course, from the purpose of the letter, not the purpose, but the content of the letters. You have very different information. So it's why the letters are very different. Also, the output is very different. There is also lots of staff difference. That's why the numbers are not the same. But we also observe some different working practice, and also a difference of lead time, which is in dermatology 26 days, and in diabetes a lead time from this process from the clinical date to the date when the letter is sent of 5 days. So what are these different working practice? We're going to break down this in 3 steps. So in the dictation process, the writing process, and the proofreading. So in the dictation process, there is a lot of different working practice using sometimes some template while dictating, which is very good for the medical secretaries, because they just have to follow this template. Some are not following, prefer to tell a story. Some, as I already said, use tape of the Olympus, of the EPIC, and each of these systems have their advantages and drawback. And also some are doing 1 audio file per day, while others are doing 1 audio file per patient, which can have an impact. For example, on a tape, when you have 1 audio file for a whole day, it's really difficult to find the right, if you want to find the precise letter inside, it's going to be difficult. In the writing process, so we have seen a lot of different practice also, but some very efficient using a preset template in EPIC. So it's just you clicking on a button, and the clinical letters is fulfilled by the clinical notes that the consultant did during the appointment. And so something a bit we observed was that many people have templates, but they are in the overall quite similar, but still some little change between all these templates. And maybe it could be the start of our ID, saying that they have all templates. Why not trying to have quite the same template for everyone, as the content is the same? And of course, when it's possible, because it's not possible in all the case, some others are not using template, but starting from a blank template. And also we saw that a lot of people are using smart phrases, which is very efficient. And the same thing for proofreading. The use of smart phrases make the proofreading very efficient, adding the header and the bottom of the rest very quickly. And but there is also some difference why sometimes it's taking 2 minutes, why sometimes 5 minutes. Is because sometimes when consultants are writing the letters, they are just writing notes and not a real letter, so they have to transform the letter. So really, I've seen a huge variety, and the main thing to remember is that the working practice are very different between departments and even within departments. And we think that there are some point in the letter, some specific areas that can be unified in some specific case that we will detail later. Then let's focus on primary care. So to understand then when the letter is sent from Edinburgh to the GP surgery, what's going to happen. So first of all, the GP surgery will receive an email. It's focused on Stapleigh Medical Center here. And as EPIC, the Edinburgh system, and System 1, the GP surgery system, do not have a common bridge, common transfer of information, they need to use emails. Then you have 4 teams involved in this process: the patient service team, the clinical admin team, medical technician, and the GP, of course. And for the clarity of this study, we only focus on the patient service team and the clinical admin team. Why? Because, as I say, there is 2 main streams in a clinical letter, which is administrative information and medical information. And this is exactly the purpose of these 2 teams. And we also identify a bottleneck because 88% of the letters were waiting between these 2 teams. It's still normal because medical information is much more difficult to pick up than administrative information. But it proved that if we are increasing the efficiency and making the life of the clinic admin team easier, it will benefit to all the process. So really quickly, what are doing these 2 teams? We are not going to deep dive into this process. Just what I want you to remember is that they are using OCR. So there is optical character recognition that help them to pick up administrative information. And today, this automation could make the process very, very efficient if a clear template is implemented. And for the clinical service team, same. What I want you to just remember is that they have to pick up some very important information and to do action from this information. If there is a new disease, if there is result, if medication is changing, and department, the follow-up. And so if this information are highlighted in the letter, it will make this process much more easier, much more faster and efficient. There are also other type of surgeries. We didn't have the chance to really deep dive on these other surgeries, but basically the main purpose of this is to say, even if our process is not suitable at 100%, our recommendation are not suitable for 100% to the other surgery, it will still help them in any way, as the process is at the end quite similar. You need to pick administrative and medical information. So what are the main issues that we identify from this analysis is that mainly because there is not a common template for the header, the OCR is not as efficient as it could be. It's still efficient, but not as it could be. Some passwords are protecting some letters, which make not sense in some cases, sometimes useful, but not in all. Some administrative information are in the core of the letter. So that means the patient service team has to go through all the letter to pick this information. And in terms of medical information, the main thing is the lack of standardization, of course, which is not possible in all the cases, but sometimes just add headings and highlight the key information that they need, like diagnosis, action for GP, management plan, result, and follow-up, could make the process more efficient, but also that they receive a lot of letters per day, letters per day. That's why it's also difficult. Next slide. It's coming. Yeah. So we did a bit of data analysis as we are engineers. So we took the letters received by the dermatology and diabetes department during 1 week. So received by Staploe from these two departments. In these letters, 20% of them didn't have the whole administrative information needed by Staploe. So then it's making the process much more longer. And out of the 39 letters we analyzed in precision, 18 there we found 18 different templates. That means 18 different kind of letters that you need to go through to understand where are the key informations. That do not mean that all the templates are not good. That just mean that you have different templates, and so even if the information is clear inside, as it's different all the time, you really need to go through all the letter at each time. And so let's move on to project findings and recommendation after mapping all this process.
You're on mute, George.
Sorry, I was controlling the slides. I think it made me go forward a bit. 1 second. Sorry about that. Hans, do you mind taking over the controls and going back a few slides? I think the Zoom PowerPoint control is a bit broken. Just go back to the first page if that's okay. Sorry, some technical difficulties. I'll still talk about the topic. So we try to see what we can do for the GP surgeries in terms of, what process of the letters could be standardized. Obviously, each letter is so different, but again, we're focusing on clinical letters, and, we try to sort of figure out where this issue, arose from. And we think it sort of, starts from when EPIC was first implemented, because, there was 3,000 letters that were sort of imported into EPIC rather than, them thinking, okay, now is the perfect time to try and standardize this. And, the best practice in terms of today for writing letters, it comes from, the Public Record Standards Body and the Please Write to Me project, as well as sort of trying to make as little change for Cambridge University hospitals. It creates a big impact for primary care and patients. So, how do we make best practice for letters? So this is like, always writing to the patient rather than the GP. This is something that's been trying to standardize sort of nationwide. So there's kind of pushback for this, but, that's just part of best practice. It kind of explains the results and findings in a patient-friendly way. Includes a section for the letter that says, okay, so as a patient, you need to take this medication, you need to look out for this appointment, lets them know what they have to do, as well as any medication. And for primary care, again, we're trying to standardize this sort of admin process and information that doesn't necessarily affect the letter, which we'll show later on, making the NHS number consistent, and also including the same format, but still allowing flexibility for consultants, if that makes sense, because that's really important. And we need to split the action so it allows a clear division of what needs to be done between, the patient, NHS, whether it's Addenbrooke's or the GP surgery, because if it says takes blood, it's not always clear if this is for the GP or Addenbrooke's or someone else. And moving forward, please. So we created a template with the GP surgery Staploe. We used multiple ones, and we found that the best case scenario, you could reduce up to 25% in the overall letter processing time for GP surgeries. And this just comes from focusing on clinic letters, because on each clinic letter, we could get up to 65% sort of a reduction in time in terms of minutes. And this comes from the aspect that, I say up to, because some clinic letters are more easy to process from the OCR and also from the admin team. So, that's what we can do for the primary care. And if we move forward, this is what we can do for the patients. So, we can, by reducing this bottleneck in the processing times, sometimes there's a delay of 4 days, especially at the beginning of the week. we could reduce this down. So as time goes on, the delay between, the GP processing this letter could, be released down to almost like 1 or some cases 0 days, depending on how staffing is. And again, this kind of starts to fit in this template with the Professional Record Standards Body and the Please Write to Me project, which is from the Academy of Royal Colleges, which, is trying to be standardized across the UK. So move on to the next slide, we can see the best case scenario clinic letter that we found for the GP. Again, don't look at this in too much detail because it's going to be broken down, but it's trying to standardize aspects of it. So if we move one slide forward, you can see animations. So there's stuff that is being standardized by Cambridge University Hospitals Trust, or they're working on it right now. I can't show you what that looks like in this case because we have non-Addenbrooke staff working here, but this will be going around. If we move forward again, there's sort of best practice in terms of this is the stuff that can be more standardized between letters regardless of the clinic. And if we move forward again, this is the best practice, and this is where it allows more flexibility. So this allows, specific departments to add relevant sections to the letter, but also this is a bit that's most important because it kind of breaks it down. So the patient can sort of, it can still include technical terms for the GP so they can make notes more efficiently, but it also breaks down that technical knowledge so a patient can understand it in a way that is friendly to them, and moving forward, again, we can see again, so I said this letterhead and the clinic contact information is going to be standardized. So I'm just going to sort of move ahead from that, because if we were to suggest changes, they're going to be changed anyway. So again, this is what the top of the letter should look like. Again, this is using the standardization. The GP surgeries want and have struggle figuring out the type of letter, whether it's a clinic letter, discharge letter, sometimes it's written all over, and their OCR struggles to pick up the date of the clinic versus the letter the letter was written or the date was dictated, and sometimes I have to flick through because that's not clear. Just changing this bit here so it's all the same. It can save between 30 seconds to a minute for each letter that's being processed by the admin team, because they'll start looking for it. And that's just from the get-go. If it was standardized, it'd probably save more time because they always know what to look for. And if we move forward again, so this is again just sort of linking to the sort of standard, at the header of each page, apart from the first page, it mentions who the patient is, the NHS number, the clinic date, and the letter date. And at the end of the letter includes a distribution list. Again, this is good for the patient so they know who has seen this letter, so they can know whether the GP has seen it, whether the consultant has seen it, stuff like that. Okay, and then moving another slide, sorry. Once again, I think the animation is a bit glitchy here. Okay, yeah, so this is the sort of, again, how do you create a low impact, a low effort for staff, so not a lot has to change for them in the way they dictate letters, whether it's vocally or written. But this is the best case scenario for GPs. They want to see this information because they can type it faster. They want to know the diagnosis, they want to know what's happened. It can be to the point because it's already explained in a patient-friendly way later on. And if they have any sort of questions, they can look at that. And the management plan, they want to know a clear distinction between what Addenbrooke's is doing, what the GP is doing, what the patient is doing. That's part of the Please Write to Me, start taking medication, continue taking this, stop taking this, an appointment will be organized soon, make sure to look out for it. And for other healthcare professionals, even if it's nothing, even if you write nil, they want to know that there's nothing, as well as medication changes. Again, this is so it can be more sort of epic friendly in terms of smart templates and smart functions. Make it clear what medication they should start taking from this consultation, or what they should stop taking. And again, this can be explained to why in the other parts of the letter. And this is the bit where most time can be saved. You can keep moving forward. So they can save about 2 to 3 minutes just from standardizing that and always putting it in the same way so it looks the same. Again, consultants can change that in a sense of what content they include. They might add another section, which is relevant to that clinic. But again, as long as that's there, the GPs can always look for the same format, the same letterheads, the same titles, same underlining. And again, this is key for the patients in terms of best practices. This section of the letter, again, it's just some, in this case, some Latin, so it's not actually English because we can't share an example of patient information. But it kind of breaks up at the beginning of the letter, what's happening, what the results mean, why there's new medication, so the patient can understand what's happening before they look into technical information. And again, concluding the letter and saying, please take this medication. If you have any issues, call this person, and also signing it off from the medical secretary and the consultant, because that follows sort of best practice from the PRSB. So it's making sure that they can sort of see rather than just using initials. Okay, and moving on again. So from just this letter alone, this is the sort of times we could get from the Stablo Medical Center. So, rather than taking an average of 5.1 minutes to process each letter, they can bring it down to 3.6 minutes. And this is for all letters, not just clinical letters. And I think that's what's important, because for clinical letters, it makes it more rapid, and it also helps them set up optical character recognition, so it can always look out for the stuff, which in theory, the patient services team that just sit there and all they do is just get, the letter date, the clinic date, and the department, that can then free them up to work on the later backlog, which is extracting medical information. And, that for the patient, NHS services, that saves a lot of time, because it's just for one practice, but, this impact would happen across, all sort of GP surgeries in the catchment area. And I think, yes, moving on to the next slide, I think now this should go to Hassan. So Hassan, feel free to take over.
Thank you very much for that, George. We'll move on to our final part of our presentation now. So we're going to move on to the summary and discuss some of the benefits and the impacts of our recommendations, and just highlight some of the key things we discussed throughout sort of the past 30 to 35 minutes really. And so one of the first things that we'll discuss is how we'll describe patient self-care and management. I believe that this is one of our key focuses in part of our project, to try and improve the patient aspect of this process. So throughout these recommendations, really we're trying to really speed up the delivery of clinical letters to the patients and effectively the treatment they will receive. And this will in turn empower the patients, hopefully to manage their condition and treatment, just by improving sort of the clarity and the structure of the letter really. And this will in turn hopefully also reduce the burden on the GPs, and will also drive just the improvement of patients' quality of life, and mitigating any risk to the safety and the health aspect of the patients. And just moving on to our next slide now as well, it's important that we also ask why it's important why you might want to pursue these proposed recommendations really. So some of the potential benefits firstly is to CUH. Firstly, that is just to reduce the operational burden on Addenbrooke's. And just by reducing the amount of patients that are going to be calling up, just inquiring about the letters, inquiring about further detail about the letters, just trying to get some more clarity really. And we anticipate that this will reduce just sort of that operational burden and that aspect. Secondly, there's also a risk to patients' health that has to be considered as well, and this will be reduced just by considering the lead time that is anticipated for these letters, which can be up to 6 weeks. And so should these patients require further treatment elsewhere, that transparency of getting that clinical letter delivered much faster will definitely reduce some of those concerns. And finally, of course, there are some potential cost savings which are very critical for the NHS. And secondly, also there are potential benefits also for the primary care. In this case, as we discussed in our presentation, there are approximately 25% reductions in processing time, which can be achieved just by the changes that we have recommended previously in the last few slides. And similarly, you will have some identical reduction in the operational burdens on the clinical admins, which will free up some time. And just by getting the letters more concise and more clear, hopefully this will reduce some of the follow-ups and just some of chasing the letters done by the GPs or patients. And definitely this will also drive the cost and resources that will be freed up as well. And finally, this will also have some potential benefits to patients as well, just by as we discussed earlier, improving the access to the treatments, and just by getting them to understand the letters much more clearly. And also as we discussed earlier as well, we try to really incorporate better self-management for patients of their own condition and their treatment, which we anticipate can be achieved through these changes to the letter. So just moving on to our final slide. So we just had some final comments and possible improvements that could also be added. So we also suggest just reducing the use of cassettes and moving towards Olympus, or some e-dictation software on Epic, for example. And we believe this should be conducted from a trust level, along with mandating and reinforcing some of the PRSP principles. And again, this should be done from a trust level and should be really be encouraged really across the whole practice. And finally, the final suggestion is to standardize the aspects of the clinical letters. And again, this is for patients and GPs, and it should be done from a trust level. So just our final comments as well, we really did have lots of, we did witness a lot of best practices during our 2 weeks within the primary care and secondary care networks. We really enjoyed seeing how patient care was always put first and delivery of high quality care patient was delivered to all. And finally, we really appreciated the warm hospitality we received and the reception from all parties to our project. And I think without further ado, we can move on to our final slide. So thank you again for taking the time to meet and engage and host us all. So yeah, any questions?
I will raise my hand.
Sure.
Sure, okay. First of all, I want to say, as someone who's been working on Please Write to Me within Cancer Services with Fiona Carey, this is like a Christmas present to me. It's just absolutely fantastic to see that you've done this research and backed up what we've been trying to promote within cancer services over the last 3 years. So thank you very much. And I look to Daniel for how we can take this forward trust-wide. We can get a lot of patient support from the Cancer Patient Partnership Group and other groups, I'm sure, so I can support with that. Just two quick comments in the sort of template letters. It was fantastic to see the consultant summary, the part at the beginning and at the end, which makes those letters feel like they're for patients. I didn't see, but I might have got that wrong, that there needs to be, like, right before that text from the consultant, it needs to say "Dear patient's name." You need to make sure you get that in there, and that's really that feeling. I think I'm quoting Fiona saying, "This letter needs to be to me."
Yeah.
And so you want to get that as part of the template. And then the other one was that in the very last slide where you talked about the benefits and the benefits for the patients, I think you could add on their dignity and respect. So being written to, it gives dignity and respect to the patient. That's all from me.
Thank you for pointing that out. Actually, you're right. In the template letter I did do, Hath, I don't know if you mind sort of jumping out of the presentation, just showing your whole screen. But on slide 29, I did actually put, you write to the patient. Just go back a bit, Hath, a few more slides. I kind of wrote at the top, you write to the patient, and instead you CC the practice and the GP.
Mm-hmm.
So it's always, "Dear, Mrs. Jane Doe," and we've CC'd the GP and doctor, and when you're writing them to you're writing to the patient, you should be expecting, an appointment, stuff like that, rather than for the GP. It's still important to include information for the GP, which is why we put it later in the letter, and we've tried to standardize that. So, they can still, it's almost, we're trying to find a perfect balance between, how do we make the patient experience better? How do we minimize, as high as an impact as possible to the GPs, while changing and, not making the process any more expensive, or trying not to make the process any more lengthy or complex for, Addenbrooke. So again, it's sort of this low effort, high impact. And you can see there in the top right, in this case, it's, Mrs. Jane Doe, and you can see there the person who's CC'd under the letter structure clinic is the GP name and the GP details. And normally it's the other way around for like 99% of the letters at Addenbrooke right now.
Yeah, great. That's high. Thank you very much.
Thank you.
Can I make a comment?
Yes.
It's Fiona here. Thanks for that. That was great. I echo everything that Lenny said. I think there's some really good ideas here. I think the topping and tailing with the basic information is a really good idea, to have that consistently through the letter and easily available. I've been patient here for a long time. I've got a lot of letters from the hospital, and a little while ago I needed to put them in date order, and it was really, really hard to find the dates, either the clinical date or the date the letter was written. because, as you said, the information was usually there, not always, but it was very hard to find because it was in a different place every time. And I think if you can persuade Adam Brooks to adopt a system where basically the shape of the letter is the same each time, it's going to make life, I mean, easier for patients, yes, but it's going to make life so much easier in the general practice and medical centres, because you just won't have to, I think somebody said early on, you won't have to parse the whole letter to find a particular piece of information. And I think you've done a very good job here, actually. Thanks. I think there was something else I wanted to say. I've forgotten it now. I'll come back in a minute, probably. Sorry.
Thank you, Fiona. Again, we're trying to find the best balance for Adam Brooks, because we think, this issue should have been worked on, almost as soon as EPIC was implemented, because it's a perfect time, rather than, when we spoke to, I think our patients did a survey of, when it first came out, there was 2,000 letters they put on the system, and within 12 months only 800 of those were used. So there's a lot of clinic letters that almost never get used but still on the system and still sort of clogging up the thing. And it's about more just breaking up a letter and making it almost into Lego, so you can put it together but parts of it is always the same, but then consultants can still sort of add parts of that letter, because it's important for a consultant to be able to still get their point across and still pass on key information. And again, we're non-medical students, so all the input we've had is why we've had to speak to so many consultants and registrars and GPs and patients as well. We have to understand the whole picture. Sorry, yes, has anyone else got any more questions and comments? Because we could talk about this for for hours. So
Can you show us the slide again that shows the kind of shape of the letter? I think it was the one before this, maybe.
yes, it was, I think, 2 before this has, but there might be animations which might.
Yeah, so it's a bit hard to see that.
Yeah, sorry.
So that first paragraph of text, about 3/4 of the way down, that would be, "Dear Mrs. Doe, we saw you today and we talked about this." So that would be the first meaty bit of the letter. That's really excellent.
So yeah, exactly.
Really,
the first thing is for the patient.
Yeah, and we appreciate that it will take some thought, certainly initially, for consultants to be using language and terminology that's going to work for patients, as well as using medical jargon probably later on with specific instructions for GPs. But the work that the Royal College, the Academy did, said that although there was a small upfront cost for doctors, actually it didn't take them long at all to get used to writing like this. And of course, it's fantastically useful for staff inside general practices as well. And we'd need to provide some sort of help and guidance with that, I think, which we've been working on for quite a long time in terms of providing alternatives to jargon-heavy letters. But I mentioned to you the family court judgment that was written in plain English, in order that the parents of some parents have learning abilities, and a legal judgment, a very high level legal family court judgment, was written in plain English completely. If that can be done, I'm sure we can crack this with the letters, and it will only become easier. Thank you. A great piece of work. Well done, guys.
Thank you. Exactly. I guess that's kind of what the idea we got from, I guess, medical secretaries and consultants. This would take some getting used to in terms of changing, in terms of writing the letters and stuff like that. But in terms of the long-term impact, at least until other solutions are considered, that it could be financial, like implementing protocols that communicate between staff. This is the best thing that can be done now. And like you said, if it takes 3 weeks for consultants to start getting used to dictating stuff from a patient point of view, or writing letters from a patient point of view, but again, it's also important to highlight other issues with the letter writing process, like password protecting documents that can take a person 5 minutes just to find the person's NHS number, so they can unpassword protect that PDF, even though it's come through a secure mail. You know, that doesn't need password protector, and you know, 2-3 letters could be processed in that time. So I think that's why it kind of, again, we keep saying we feel like it has to come from a trust level. And I think that, you know, I think that's also why we were brought here, because I think, you know, from a trust level, it's been seen as an issue that needs to be worked on. And hopefully what we've done is just like the beginning of that sort of movement, you know, assuming this goes forward, because that's why we've done the research. So yes, thank you.
If I may add something, is just for all of this to be useful, the next step will be, of course, to try to understand how to implement this. And we will try to assess this part a bit in our final report that we will send you next week. But this is then the most important part. It's how to make secondary care confident in this template, and make them use it the best way without taking more time. Thank you so much, everybody. And if you don't have any further question, I think we can go.
I've got a question. So this is I think a fabulous piece of work, and I think an important part of the strategy for the hospital over the next period is going to be trying to think more about this kind of thing. So Sarah and colleagues, we've been doing quite a lot on listening to patients more about their experiences and how we can communicate with patients, both listening, engaging, but also just in the day-to-day way we interact with patients, being, you know, constantly taking feedback and improving. Another element I think is key is how the hospital works with partners outside the hospital in primary care, recognizing that, you know, for our patients, that we are sort of the NHS as a whole, and we have all these kind of barriers that we put between GPs, hospitals, and they're important in many ways, but we want to make the process as seamless as possible for patients. One question that we think about quite a lot within our team, which as I say is the strategy team at CUH, is how we can make it easier to work with teams in the hospital and primary care and patients on these kind of very practical things to make things better for everybody. And I think what you've said very clearly is there's the potential here to do something that's better for patients, better for GPs, and better for the hospital. So one of the kind of difficult things is, why is this so difficult? Why do we find this so difficult, and how can we do it better? So I'd be really interested in your thoughts really on, you know, you focused on one area, but there'll be 100 other areas where, again, we could make things better for everybody involved, but for all sorts of reasons, that's very hard. So I'm really interested in your thoughts on the process of doing this project. What's made it easy? What could have been easy? How could we do this better, you know, in lots of other areas as well as this? And then also, I suppose, thinking about moving to implementation. You know, you've done a fantastic piece of work, but there's a limit to what you can do in 2 weeks.
Yeah.
How can we start to make this happen more in practice?
Okay, so I guess the best example that we saw in terms of how this letter could be implemented from speaking to consultants is creating like smart templates, but rather than the whole letter, just parts of the template. So for example, the top half of the first page here would be 1 click. So that would always be the case for the whole department, right? And then, you know, the consultation summary would be another button that would paste that, and same with the management plan. So for each clinic, they almost have different buttons that could be almost like a Lego block. And because, for example, the medication, again, this was taken using an existing like Epic template, you know, it's just a matter of, you know, getting all the parts together and making it. And I think, like you said, I think the issue is because when Epic was first implemented, there was so many issues, and, you know, it's only now that it's kind of, you know, being, you know, consultants and departments are thinking, actually, wait, how can we standardize this? And the issue is there is standardization, but within clinics and departments. And, you know, and that's why there is movement for this. And that's why, you know, so many consultants and registrars and, you know, medical secretaries are so happy to, you know, try and get us to help them. But again, that's why we think, you know, you almost need someone from each sort of department to come along and, you know, put an input into this. And again, it's important to, you know, put that, you know, patient focus, because like you said, the main thing for NHS is patients, and, you know, anything that can help that process is, you know, the key thing, you know, and it just has no malicious intent when it, you know, does anything for a patient, right? But sometimes, like you said, it comes across as if like there's no thought put behind it when there has been. And I think that's what aspect this letter's trying to solve. And also I can see Fiona has also got her hand up, so I'm happy for.
I have, but Lenya had hers up first, actually.
Oh, sorry.
Thank you,
I know what
Fiona.
Lenya's going to say, actually.
Well, in sort of direct response to Dan's query, this has been a mini project within, well, it's been a big project within cancer services, but mini, you know, within the CUH. And, you know, we've been chipping away at it for 3 years. And the challenges have been time. So time from consultants, from GPs, and from the patient volunteers. You know, they're very committed, but you can also imagine with COVID, you know, we just had to pause completely and trying to get people back in. That then will affect the momentum of a project. And you know, and that affects your you know, your willingness to put more time in. So momentum is really important. We're also trying to implement a cultural change, and you know, for some people that's just not going to happen. It's just, you know, I don't want to say the wrong thing here, but people can be very set in their ways in how they write letters, and they're not interested in change. It has not been mandated. It has been recommended from a very senior level within cancer services, but that isn't enough. And the final thing is that, you know, we just have to carry on and keep pushing it through and getting that senior level support to be able to, you know, to make it a trust-wide cultural change, I would say. Fiona, do you want to add to that?
Well, yes, I mean, it has, you know, it's got a bit stalled because of COVID and so on. We do appreciate how much work this is. You know, it's easy to assume it's a question of writing Dear Mrs. Blogs on a letter, and of course it's much more than that. But Dan, I was really sort of intrigued by your saying, you know, how do we do these projects? How do we work together on them, really, and to take them forward? And, you know, our stance in the Cancer Patient Partnership Group and the work that's being done to develop the new cancer research hospital as well is that we've got a lot of patients who are involved and working with staff at the hospital in a co-productive way. You know, working as equal partners with staff at the hospital, staff of lots of different kinds. And the point about it really is that, you know, we are obviously stakeholders along with staff in any changes that are made. And the truth is that patients, you know, we see things you don't see, we know things you don't know. You've got patients with immense experience and knowledge and skill sets and so on. And it just kind of makes sense to involve us in projects as soon as they're dreamed up, really. We tend to say that a patient's place is at the table, you know, involve us at a blank piece of paper stage. And we firmly believe, evidence from here and from lots of other places as well, that if you involve patients in a project early, you will deliver a better project for everybody sooner and actually at less expense than if you ask us once 80% of the decisions have been made. And I'm sure, you know, there'll be people willing to come forward and help you in whatever it is whatever sorts of things you're thinking about doing.
I was just going to add from the theoretical point of view. I think the guys mentioned this earlier on. The easiest way with cross-boundary issues is shadowing secondment by evangelists, but that goes straight back to the point that Lenya made, which is that requires a lot of resource. Yeah. But it is very, very effective. It's the old saying of, you know, walk in somebody else's shoes and you understand their pain, you know, and that works so much better than any other medium.
So can I just throw something in that I forgot to say I put in the chat is we need to go to the beginning. We need to teach the students, the medical students, to write to the patients, to use a template, and then it'll slowly filter through it. It can start there.
Again, thank you guys so much for this input. I think it's also important to say, aspects of this letter can be standardized and should be. And I think for now, other parts should be like highly recommended until they're slowly standardized and sort of forced by the trust. Because like we said, even if half the letters use this, and like you say, half the consultants don't want to change, and you know, they're professionals in this case, that's still time saved for the patient. It's still better letters for the patient. It's still like resources saved from the GP and that's more effectively used. So like any implementation of this will have like an impact, right? And sorry, I can see Dan and Fiona also have a point to say, so I don't want to.
No, I'm done.
Okay, thank you.
That's great, thank you, George. I just with an eye on the time, I just wanted to share a final thought. I mean, the first thing to say is thank you. You've all done a huge amount of incredibly valuable work, and this has been a great presentation. I'm really excited by this. You know, I think what I've heard is there's a lot of variation in practice. You've given us the evidence to do something about it now. And for me, there's a real call to action on some of those efficiencies, kind of showing us how much of a difference writing a letter can make in primary care and to patients in hard numbers is really tangible. I think you've given us some very practical steps we can look at, you know, 1 audio file per patient, don't password protect things where they don't have to be, but send them securely instead. You know, you've talked about greater structuring of letters, how that will help with OCR, that will help with how letters are processed in primary care. And you've talked about, you know, the benefits which will come from this. So empowering patients, less need to follow up, speedier actions for clinical care, freeing up administrative time. So, you know, I think what we can do from CUH is commit that we'll look to act on these recommendations. I'm going to get some time with our Director of Improvement and Transformation in the new year. I'll talk to her about this. We'll explore things like how we can share these insights widely, including as part of the medical training process. I think a part of it will have to be an expectation that we act in the best interests of our patients, and writing clear, structured letters is an example of how we can act in the best interests of our patients. I'll also be looking to get a bit of support from our EPIC team and from our improvement team to do some work with willing specialties, to standardize certain templates which can be used where consultants are willing. And I think hopefully that, combined with sharing the insights of the impact that doing that could have, will help to galvanize action. This is a very personal and kind of, you know, every consultant likes to do things differently for good reason, but I think helping people to understand the impact of their actions is the first step to helping get them to change and benefit our patients. We're at time, so we probably have to wrap, but thank you again. And I look forward to your final report, and we'll definitely circulate materials and recording to people who couldn't attend.
Thank you, Daniel.
Thank you. Happy Christmas. Happy New Year.
Thank you very much. Have a Merry Christmas.
Yeah.
Thanks all.
Thanks, well done.
Bye.